Doctors, we are live. You can start the session.
Okay. Okay. My screen visible?
Yeah.
Okay. A very good afternoon to everyone. So today we are back with YOSI iROCK first semi-final session. So I'll play the video first. So welcome once again. So this is the Team YOSI 2024 to 2026 Governing Council, and which is headed by Dr. Devakant Mishra as the president. And this is the overall committee comprising of very dynamic young ophthalmologists for the year 2024 to 2026. So these are all the curriculum with which YOSI is conducting right now, and everyone is more than welcome to come and participate in all of this. So this is a Team YOSI iROCK, and this is a unique logo of YOSI iROCK. So already there had been 8 prelim sessions which have been conducted by YOSI iROCK, and today is the first semi-final session. So in YOSI iROCK, each team will have 3 members, and members can be from different institutes or colleges as well. Only junior residents are allowed. SRs can participate in separate fellows face-off event. The top 2 teams from each prelim goes to the further rounds, and prizes will be awarded to top 10 teams of each round. We'll announce the results after concluding the session at same evening, and e-certificates will be awarded to all the participants. Now, the finalist team, YOSI iRocksters for YOSICon, and will compete physically at YOSICon in New Delhi, which is going to be conducted from 5th to 7th of September. And they will also be awarded travel grants for YOSICon. The finalist team, all members need to be physically present at YOSICon to participate, and top 3 teams in grand finale of YOSICon will be awarded travel grants and also be titled YOSI iROCK Superstars. So there will be 4 rounds. The first round will be the iLeak, that is a seminar presentation. In the second round, which is known as Pupils Got Talent, it's a creative round. In the third round, it's a new round today, that is the Knowledge Nexus Guess What. And in the fourth round, Wordsmith War, it's known as the Great Find. And audiences also are welcomed because there are prizes to be won as well. So Dr. Roma, please introduce the judges.
Hi, good afternoon, everyone. It's my privilege to introduce our esteemed judges. Our first judge for the session is Dr. Tejas T. Shah, sir. He's a dynamic and dedicated ophthalmologist whose work continues to uplift the standard of eye care in Ahmedabad. He's a founder and MD of Ahmedabad Eye Laser Hospital, and Goodbye Glasses Laser Center is his other upcoming venture. And these are under the concept of group practice, a neutral surgical center since 1992. He was the first to introduce surgical skill transfer course in AIOS. He is pioneer in performing conductive keratoplasty, camera inlays, restore multifocal IOS. Over 36 years of clinical practice, his influence has extended beyond the clinic. He plays pivotal role in state and national conferences, shaping education and practice for decades. His contribution to digital knowledge sharing, especially his WhatsApp group, What's Ideal but What is Practical, of more than 2,000 ophthalmologists across country, has built a vibrant space where ideas meet experience, theory merges with real-world practicality. Thank you so much, sir, for building a community that sharpen our thoughts and improve our practice. We welcome you here for this platform.
Yeah, many thanks, Dr. Roma.
Next with us is Dr. Anurag Mishra, sir, from the land of Jagannath. He is the director of Radha Raman Eye Hospital, Cuttack. and Car Vision Eye Hospital, Bhubaneswar. After his MBBS and MS, he has done long-term fellowship in IOL and Pediatric Ophthalmology and Strabismus from Arvind Eye Hospital, Madurai. He is a distinguished practitioner with over 25 years of experience, passionate about technology, and has state-of-art equipment at his center. He is widely recognized for his expertise in managing complex cataract surgeries and refractive surgeries. He has performed many live surgeries, and in almost all the conferences, he has a record of more than 96 live surgeries. He has 15 publications credited to his name, a respected educator and a speaker who has delivered more than 65 faculty talks in India, Sri Lanka, and Bangladesh. And his famous lectures are on managing complex cataract surgery and also in career option after post-graduation in India and abroad. Welcome here, sir.
Thanks, Yosi. Thank you so much. Looking forward.
Next with us is Dr. Ritu Nagpal ma'am, a name that resonates with surgical fineness, academic excellence, and unwavering commitment to patient care. She is a cornea consultant at Goyal Eye Group Hospital, New Delhi. She has done her MD from AIMS, New Delhi, followed by she has done her fellowship in cornea and anterior segment from LV Prasad, Hyderabad. Her passion for teaching is equally commendable, whether she is guiding the postgraduate, conducting hands-on workshop, or leading through provoking discussion. She inspires a culture of continuous learning. She has several index journal publication and book chapters to her credit. Welcome here, ma'am, to this group.
Thank you, Dr. Roma, for the kind introduction, and thank you, Dr. Mosmi, for reaching out and for the invitation.
You are most welcome, ma'am.
Next is Dr. Vinod Tarunachalam, sir. He is a medical director of Vinod Eye Care Hospital and founder of Trichy Glaucoma Foundation. He has done his MS Opthal from Annamalai University, followed by a glaucoma fellowship from Arvind Eye Hospital, Coimbatore. He is a senior consultant at Arvind Eye Hospital for over 7 years, and he has performed more than 7,000 cataract surgeries there. He has also contributed to numerous rural outreach programs. He is a passionate academician and has multiple publications in reputed journals and has been a faculty at various national and international forums. He is a recipient of Health Icon Award 2025 and ranked among the top 3 ophthalmologists by Trichy. Privileged to have you here, sir, with us. And thank you for being here. We'll be looking forward for your valuable insight for this session.
Thank you, Yosi, for this opportunity. Thanks, Samir, for reaching me out for this event, and thanks, Dr. Prasanna, for letting know about this iROCK concept also. Thank you.
Next, I'd like to introduce my co-moderator, Dr. Nupur Goyal ma'am, who is the team lead, and she is the silent force behind each successful session of YOSI. With her ever-smiling presence and tireless effort, she has bring a spirit of teamwork and positivity to every event. She has completed a long-term fellowship in comprehensive and oculoplasty from LV Prasad, Hyderabad. She is currently working as a consultant in anterior segment and oculoplasty at Eye Care Eye Hospital, Noida. She has keen interest in academics and teaching. She is a YOSI executive member and YOSI socio-cultural team leader also. She has she's also a managing editor of Yo Times. Welcome here, ma'am. I am myself Dr. Roma Johari. I am working as a glaucoma consultant at Sri Shankar Nethralaya, and I have done my MS Ophthalmology from CMC Vellore, followed by my glaucoma fellowship from HV Desai, Pune. And I've also worked as a senior associate at Hinduja Hospital, Mumbai. And I have been awarded the PI Thomas Gold Medalist Award in my MS, and I'm also editor of Journal Current Medical Issue. I'll also like to introduce my co-moderator, Dr. Sameer Chaudhary, who's like a rising star in ophthalmology, very fast in surgery, sharp in academic, and ever active in webinars and presentation that inspires the peer and the student alike. So he has done his MS Ophthalmology from Arvind Eye Hospital, Madurai. He's a consultant at Arvind Eye Hospital, Madurai. He's an executive member of YOSI, more than 25 publications in peer-reviewed journals, 3 book chapters to his credit, reviewers for international journals, and he has conducted more than 4,000 cataract surgeries. He has also served as a formal SICS and PECO trainer. He's also a part of PG orientation program in 21 and 22. He has also numerous presentation and accolades at states, national and international conferences. Welcome here, and thank you, Samir, for being a part of it. Next, my co-moderator, who is also my perfect co-pilot for today, with her sharp, supportive, and always a step ahead things to make this session effortless, Dr. Mosmi Banerjee. She has done her MD from RP Center of Ophthalmic Science, AIMS, New Delhi. She has also completed her senior residency in PECO Refractive Retina, UVA and ROP services from Dr. RP Center, AIMS, Delhi. She is a vitreoretinal consultant in Narayan Netralaya, Bangalore. She has more than 60 publications credited to her in national and international conferences. And she has also won many awards, the best paper of the session, Neuro-Ophthalmology at AIOS 2020, winner of free paper session in SAO 2023, second position in APO Imaging Contest 2024. And international, she has also won many international travel grants, SERB travel grants, and Professor Yasuo Tenno travel grant. Thank you, ma'am. Thank you for being
for the kind introduction. Sorry. I would like to invite Dr. Samir to introduce the participants now.
Thank you, Mosmi ma'am and Roma ma'am for the brilliant introduction. So with this, I'll be introducing the participants of our first semi-final of the iROCK session. So we have team Optic Oracles from Dr. Virendra Laser Phacosurgery Center, Eye Hospital, Jaipur, which is led by Dr. Gagandeep Kaur and Dr. Amisha Mathur and Dr. Akshita Ghia. Next team would be Team Macular Goals from Arvind Eye Hospital, which is led by Dr. Smriti Soni Thampi and has Dr. Priyanka and Dr. Arvind Krishna as her teammates. Then we have the Team Annulus of Win from KMCT Medical College, Kerala, led by Dr. Hiba with Dr. Sruthi and Dr. Haifa as her teammates. And we also have Team Synergist Squad, again from Arvind Eye Hospital, which is led by Dr. Shobana and Dr. Neha Rashid and Dr. Vinita as her teammates. Then we have Team Site Seekers from KGMU Lucknow with Dr. Anvi Alakshay, Dr. Anvi Jain, and Dr. Ritik Jain. And obviously, this entire initiative of iROCK wouldn't have been possible without the support of our governing council, especially Dr. Devakant Mishra, Dr. Nilesh Kumar sir, and Dr. Prasanna V. Ramesh, or Dr. PVR as we fondly call him. So now I would like to invite Dr. Prasanna for his our dynamic joint secretary to deliver the GC address. Over to you, sir.
Thank you, Samir. I'll make it quick. I don't want to stand in between the competition. So YOSI iROCK has been a brainchild of Dr. Devakant, Dr. Nupur, and the whole YOSI team that you are seeing here today. 3 people being here to moderate is Dr. Samir, Dr. Roma, and Dr. Mausmi. And it's a team involving more than 10 to 15 people who are working day and night to make this a wonderful hit. And for the viewers here, they have had 8 episodes, and this is going to be the semi-final round. We are going to have 3 semi-finals, and then we have 7 teams which are going to join us at the annual Congress of YOSI, which is YOSICon, which is going to happen at September 5, 6, and 7. And all the best to each participating team. And 7 of you guys would be there at YOSICon to fight it out physically. And thank you for being here. And we have had a tremendous pan-Indian participation in the last 8 episodes, as you would have seen, completely from Kashmir to Kanyakumari, from Ahmedabad to West Bengal. We had a total complete participation, and the judges for today, Dr. Ritu, Dr. Tejas, Dr. Anurag Mishra sir, Dr. Vinod sir, really thank you for taking your time in being here to judge and encourage the young ophthalmologists out here, and to all the mentors out here. So when we started this program and when we reached out to the mentors of YOS in premium institutes, each one of them supported, and I can see Dr. Sharmila ma'am from Madurai also attending this meeting, and many senior mentors to mentor their team. So congrats and best wishes to Team Synergist and their captain, Dr. Shobana, Team Site Seekers with Dr. Anvi as captain, Team Optic Oracles, Dr. Gagan, Team Macula Goals, Dr. Smriti, and Dr. Team Analyst of Win, Dr. Hiba. And you guys are doing a phenomenal job, and keep on the great work. And I would like to thank Team iROCK, Dr. Devakant, Nupur, as well as the whole team for having me here, and looking forward to seeing you all at YOSICon, which is going to be our culmination of this 14-month event. So all the best and rock it. Thank you, Sam. Over to you.
Thank you so much, sir. So with this, I'll just share a very brief outline of our session. So we have 4 rounds. Round 1 is basically iLeague seminar, where the participants will be a person from each round will be presenting on a particular pre-allocated topic. Then we have round 2, which is Pupil Got Talent, where the participants, the teams will be showing their creativity and presenting a topic of social awareness pertinent to cataract, either in a form of a reel or any other creative form. Round 3 is knowledge nexus. Guess what? Where a question will be projected and the participants have to answer after being provided with certain hints. And the final round would be Wordsmith War, where a grid of jumbled words will be there and the student or the participants have to identify them. So we'll start with the first round, which is iLeague seminar. So one member from the team will present on a pre-decided topic. But the presentation time would be 5 minutes, and there is negative marking for if they exceed that particular time limit. After each presentation, there will be 2 minutes allocated for question and answers from the judges. And depending on their ability to answer the the specific questions, the marks can be given. So the team optic oracles will be presenting on OVDs of ophthalmic viscosurgical devices, team macular goals on A-scan, team annulus of non-toxic anterior shock syndrome, team synergistic squad on capsular support devices, and team site seekers on management of intraoperative complications of cataract. So we'll begin with the first team, which is team optic oracles, and they'll be presenting on ophthalmic viscosurgical devices. Over to you, team optic oracles.
Thank you, sir. Good afternoon to all. Today I will be presenting on the topic of ophthalmic viscosurgical devices, which are also known as viscoelastics. They have viscous, elastic, and pseudoplastic properties. First introduced in 1972, but sodium hyaluronate got its trade name Helon in 1980. Term viscosurgery is also used to describe surgical procedures which use these solutions. Ideal OVD is the one which is optically clear, inert, non-toxic, non-inflammable, non-pyrogenic, non-immunogenic, and sterile. Ease of effusion through cannula should be there, and retention under positive pressure should be there. Adequate protection of endothelium, easy to wash out, and low risk of post-op increased IOP. Rheological properties includes viscosity, which describes the resistance to flow, and it's the faster the flow, lower the viscosity, and at rest it is maximum. Viscoelasticity is the property of a substance to retain its original form after being stretched or deformed. Pseudoplasticity is the ability of a material to change from being highly jelly-like to highly watery in under stress. And surface tension is the property which allows the coatability. Lower the surface tension, better coatability. There is a term called cohesive dispersive index, which is the percentage of viscoelastic aspirated, and it is more than 30 in cohesive, less than 30 in dispersive. The components are sodium hyaluronate, which is a highly viscous biopolymer with half-life of 1 day in aqueous and 3 day in vitreous, and mainly is present in cohesive visco. Chondroitin sulfate, on the other hand, is low viscosity OVD, which is obtained from shark fin cartilage and mainly present in dispersive visco. HPMC is also a low viscosity OVD, which doesn't naturally occur in animals and a component of plant fibers. Classification as given by Archinov based on the rheological properties is high viscosity, which are cohesives, low viscosity, which are dispersives, and viscoadaptives. This is a tabular form of the properties and other features. Higher viscosity ones have higher molecular weight, viscosity, pseudoplasticity, surface tension, and thereby less coatability. It is inverse in the dispersives, that is the low viscous ones. And viscoadaptives work as both. The examples of the viscoadaptives are Helon 5 and the others are mentioned in the table. The advantage of the higher viscosity ones are they help to create space, induce and sustain pressure, and easily removed. Whereas dispersives, they have excellent coating quality and thereby endothelial protection and better retention during phaco. And disadvantages of the cohesives are that they're greater tendency to escape, lesser endothelial protection, and might cause secondary glaucoma to higher degree as compared to the dispersives. Dispersives, on the other hand, they do not maintain or stabilize space and can obscure the view, and they can also cause secondary, and the very complete removal is quite difficult. Clinical uses is seen in cataract surgery to protect the endothelium, maintain AC, for intraoperative mydriasis, capsular access, IOL implantation, and also lubricating a cartridge or folding a lens. In cornea surgery, they are used in DAL for viscodissection and trephination to maintain the AC, and it can also be used in intraoperative floppy iris syndrome through soft shell or ultimate soft shell technique. In glaucoma, in mix and viscocanalostomy, and posterior segment surgeries to provide a temporary tamponade or surgical dissection of membranes. In pediatric cataract, because the capsule is so elastic, so cohesive comes in handy. And in canalicular trauma, to localize it, we can use fluorescein viscoelastic. Visco staining uses 0.4% trypan blue and visco anesthesia 1% lidocaine incorporated into visco itself. There are certain techniques as described by Arshinov. There is soft shell technique in which one layer above is dispersive and inner one is the cohesive. The amount or the cost effectiveness was not there. So ultimate soft shell technique was invented in which the above layer is the viscoadaptive one and the lower one is the ultimate low viscosity like balanced or solution or trypan blue, and Stysoft is the one in which the above one is the dispersive, middle is cohesive, and innermost is the BSS. To remove the OVDs, we have two techniques, either the rock and roll technique or the two compartment technique. In rock and roll, irrigation aspiration probe is used to rock the IOL, and in two compartment, we take it behind the IOL so that it can be completely taken out. The complications that they can cause postoperatively are secondary glaucoma, capsular block syndrome, pseudo-anterior uveitis, crystallization of IOL surface, calcified band-shaped keratopathy. Some of the commercially available viscosurgical devices are shown in this slide. These are my references. Thank you.
Thank you, team Optic Oracles. That was a great presentation, very well covered. So I would like to invite Dr. Anurag sir for his comments and questions.
Yeah, thanks, Samir. I completely agree with you, Gagan. That was. Does everybody hear a sound? Okay, all right. So thanks, Gagan. That was actually an amazing presentation. I never knew when I saw the topic at the beginning of this particular event, I didn't know that you could comprise so many things under the heading of OVD. Really, really well done.
Thank
Two
you so much.
questions. One is you rightly pointed out that the hyaluronate and the chondroitins are derived from animal sources and the methylcellulose is derived from plant sources, but you forgot to mention which plant is it derived from? So that's my question number one. And question number two is, although it has numerous advantages, the OVD use in clinical practice and surgical practice, which are the situations where you should be on your watch before injecting too much of viscoelastic into the anterior chamber?
So regarding the plant, I am not quite remembering the exact plant that they are derived from. Sorry, I will read up upon that. And regarding the cases that we should be aware of, the cases which are already predisposed to being higher IOP after post-op, such cases should be taken in mind that not much visco should be used. And
Okay, should I give the answer quickly? The first answer is actually, again, as far as I remember, go and check. I think it's cotton plant from where methylcellulose is derived.
It's starch based.
It's
Anurag.
cotton plant,
So I
polysaccharide.
call it potatoes. Yeah.
It's
And
polysaccharides.
HPMC is power potato.
Comes from the cotton plants. And the second is you should be mindful wherein the capsule is not integral, both anterior and posterior. If there's a breach in the capsule, you should not be injecting too much of viscoelastic because it itself forms a load and that might just cause the capsular break to widen up. Thank you. Very well done.
Thank you so much, sir.
Can I ask a question?
Yeah, please, sir.
Yeah. So, Dr. Kaur, you did mention an ideal OVD. Do you know which is the most ideal OVD present?
So as far as I have read, I am not able to find the OVD which has all the properties that have been mentioned. So to name a particular OVD would be difficult for me.
Frankly, I'm pulling your leg. The best OVD is nothing but what we get when we have a PCR, and that is a vitreous. That's the best OVD. Okay, great. Coming back to the academics, you did mention soft shell technique, and that is the way in fact, almost everybody practices. And you also mentioned all the three variations. Though I don't find the third variation of putting BSS, that is too much for too little, right? So I believe practically it's it's still the soft shell technique which we keep on performing with a cohesive and a dispersive. When will you use a cohesive viscoelastic? One quick answer, just one situation.
So in cases where there is a high intralentricular pressure, for example, in tumescent cataract, then we would need the cohesive for the Nexus. And so for cases of pediatric cataracts, in which
no, I think when you have high intralentricular pressure, you can still use sodium hyaluronate also. In fact, sodium hyaluronate is one of the best viscoelastics to perform that. For a cohesive, I would say the best one is when you want to plug the gap. So which is like a PCR. When there is a vitreous herniation, you would definitely want to plug it with the help of a cohesive viscoelastic, dispersive viscoelastic like a viscoat.
so
Okay. Yeah, over to other moderators or judges.
Thank you, sir. Now I would like to invite Dr. Ritu ma'am for her comments and questions.
Hey, it was a very nice presentation, very nicely summarized and quick short points. I just want to have one question. Which is the viscoelastic which you prefer while injecting your intraocular lens?
So, ma'am, I would prefer the cohesive one to maintain the anterior chamber and the space so that there is easy implantation of the IOL.
And which viscoelastic it's easy to take away during viscoelastic at the end of the surgery, which easily
Cohesives are the one that are easier to aspirate out, whereas dispersives are more difficult as they adhere to the structures, instruments, and all.
Thank you.
Thank you so much, ma'am.
Thank you, ma'am. Vinod, sir, your comments and your questions.
It was a nice presentation by Dr. Gagan. I think most of the questions have been covered by other judges. So let's move on to the next presentation. Maybe next we will see and we don't want to waste time.
Thank you so much, sir.
Thank you, sir. So I would like to invite Team Optic Oracle's mentor, Dr. Nikita Jain. Ma'am, are you there?
Yes, sir.
Yeah, just few words from you.
Yes, sir. So I think it's a great initiative by YOSI to appreciate and promote this kind of a competition, which also helps the young residents to explore the subject more. And Gagan has spoken really well about the topic, and all the very best to all the teams. Thank you.
Thank you, ma'am, for sparing your time and coming and giving your words of encouragement. We also have Dr. Kaushalya, who's a mentor of the team Synergic Squad. She won't be available in the later half of the presentation, we'll take her comments now itself. Kaushalya, ma'am.
Good morning, YOSI team, and I wish all the best to our Synergic Squad team, Dr. Vinita, Neha, and Shobna. And this is a very great initiative, Dr. Samir and team. I wish you all the best. Best wishes to everybody.
Thank you so much, ma'am. Thank you for joining us today.
Thank you.
Thank you. So with this, we'll move on to our next team and the next presentation, which would be Team Macular Goals, who will be presenting on A-scan. Team Macular Goals, you can share your screen now.
Yes, sir.
Good evening all. I'm Dr. Priyanka from Team Macular Goals, here to present about A-scan biometry. This slide shows the evolution of ophthalmic ultrasound. So, biometry means the application of mathematics to biology, and here to measure the axial length of the eye. The two types include ultrasound biometry and optical biometry. In ultrasound biometry, we have the immersion and the contact technique, whereas in optical biometry, we have these following principles. Moving on to the basic principle of ultrasound biometry, it works on the basis of piezoelectric phenomenon where the probe emits a high frequency sound wave around 10 megahertz in frequency, which has low penetration but high resolution. When these encounters an interface which is dissimilar to the present one, a part of energy is reflected back and a part is projected through. More dissimilar the media, more stronger the echoes. This table shows the velocity of sound waves in different media inside the eye. Based on this, the average sound velocity is calculated, which is different for phakic, aphakic, and pseudophakic eyes. In pseudophakics, we need a correction factor based on the material of IOL used. So in ultrasound biometry, we calculate the axial length from the anterior corneal surface to the internal limiting membrane with the formula distance, that is length, which is equal to the speed of sound waves multiplied by the time taken for it to reach back in a given media. In contact method, the probe is in direct contact with the cornea, which produces the first spike, followed by 2 spikes corresponding to the anterior and posterior lens capsule. Then it travels through the vitreous and produces separate spikes for retina, followed by sclera, and then for orbital tissues. So, a high quality A scan will have 5 high amplitude spikes, a steeply rising retinal spike, and 2 separate spikes for retina and sclera. Moving on to the immersion technique, here the probe is in direct contact. The probe is immersed in saline, which is filled in a scleral shell, either Hansen or Prager shell. So high quality immersion A scan will have 6 high amplitude spikes, separate one for the probe and cornea, and the corneal spike will have 2 peaks for the epithelium and endothelium. Some important tips for getting good high amplitude spikes are the probe should be parallel or coaxial to the visual axis to get the maximum amount of reflected echoes, and the macula should be smooth and regular. Important tips to remember: to avoid indentation, we can use the immersion method or hole by the wire technique, or the corneal compression can also be measured by measuring the anterior chamber depth. Iris has to be parallel to the floor, probe has to be perpendicular to the iris plane, and eyes should be properly fixed to get a good A scan. Some errors in spike are: when beam is not passing through the center, we'll get a short posterior lens spike. When it is misaligned along the optic nerve, there will be no scleral or orbital fat spike. And when the beam is not perpendicular to the macular surface, there might not be a retinal spike which is steeply rising. Consequences of these errors are: even 1 millimeter change can lead to a difference of 2.5 diopter change in the power. Shorter eyes are more notorious because even a 1 millimeter change can lead to a change in power of 3.75 diopters. Some critical points include: always measure both the eyes and remeasure if the difference is more than 0.3 mm between the eyes, and difference of more than 0.1 mm in consecutive readings of the same eye, and if there is short or long axial length. Special situations include posterior staphyloma, where we can perform a B scan along with the A scan. For denser cataracts, increase the gain. For pseudophakics, use the appropriate correction factors as told earlier. Sound waves tend to travel slower in silicone oil, so if proper velocity settings are not used, it might show an erroneously long axial length. Moving on to the disadvantages of ultrasound biometry, it measures the anatomical axial length, that is till the internal limiting membrane, and it needs an experienced operator, all of which can be changed as advantages of optical biometry, where it measures the optical axial length from the cornea to RPE Brooks membrane. It is less operator dependent. It can measure both axial length and keratometry readings, and it has integrated IOL power formulas. These are some of the available optical biometers. The IOL Master 500 works by the principle of partial coherence interferometry, where it measures the anterior axial length, anterior chamber depth, keratometry, and white to white. IOL Master 700, additionally, because of its SSOCT principle, can penetrate even denser cataracts. Some disadvantages include: these are expensive, patient needs at least 6x60 for fixation, and it's not suitable for patients with nystagmus, tremors, or lid abnormalities. Thank you.
Thank you, Dr. Priyanka and the team Macular Goals, for a lovely presentation. Probably one of the most important investigative tools in the field of ophthalmology. So we'll start with Dr. Vinod sir for his comments and his questions.
That was a nice presentation. So in case of ultrasound during A scan, if it post refractive surgery, so what would be the procedure, and how will you do the preoperative workup for the post classic cases? Or
Sir, for the post refractive surgery cases, ideal is to do the optical biometry where they'll have a prefixed modes for and or else we can have online calculators where we can enter the
See, everywhere they don't have the optical biometry. So if there is only optical ultrasound is there, so how would you manage? Or what is the formula? What is the formula which we use to calculate the IOL power for post refractive case?
Actually, I'm sir, we have an online calculator in which we can measure the axial length keratometry readings and we can enter it in that to get the most ideal intraocular lens power for post refractive.
There is a formula. It's better to look and find out. If I say, then it won't be nice. Better if you look out and then find by yourself.
Okay, sir, sure.
Thank you, sir. Thank you for your comments. Dr. Ritu, ma'am. Ma'am, are you there? Okay, I would like to ask Dr. Tejas, sir, for his comments and questions.
Yeah. Hi, Samir. Excellent and a very feisty presentation. We had very little time to cover such a vast topic. So very important now, the days are going to be probably every 1 out of 2 cataracts is going to be post-refractive surgery. The number of refractive surgeries are increasing. So it is very important that you also mention how you are going to measure the keratometric readings. What is the relation between error in keratometry reading versus the diopters in IOL power calculation?
So for the keratometry, like 1 diopter change in keratometry can lead to 1 diopter change in the IOL power reading, sir.
Correct. Now, that is which part of the cornea you are talking about?
The central cornea, sir.
Yeah. So how much?
Central 3 to 4 mm of the cornea, sir.
Correct. So this is the part of the cornea which is actually absolutely altered. Are you aware of any other parameters which you should always look for, apart from doing a keratometry, apart from doing an ultrasound?
So pachymetry to assess the corneal thickness.
I'm talking of the corneal layers. No problem. That's your homework.
Okay, sir. Sure.
Samir, you can switch to Anurag.
Thank you, sir. Dr. Anurag, sir, over to you.
Yeah, the first is a comment. Apart from, and you rightly mentioned that the eye has to be absolutely parallel to the floor when the patient's lying down and you're measuring the axial length with it. And if the eye is not parallel to the floor, as you rightly mentioned, the capsular spikes will be different from one another in terms of their height. What you should also look at is the iris spike coming in at times when the eye is not parallel to the floor. So that comes before the anterior lens capsule spike. So that's also something that will give you a clue, because believe me, with the Prager shell, with the immersion scan, the days I was doing it, I've seen that even if the eye is not parallel, the spikes are so similar to one another, it's impossible to distinguish. Even the fat spikes come in naturally because there's just that little iris spike that comes in, which tells you that the eye is not parallel to the floor. The second is a question. Should you wish to use the modern IL calculating formulae, can you use them with an ultrasonic biometer? And if you can, then what should be the correction factor used? The first question is, can you use them?
Sir, some of the earlier IOL calculating formulas which takes
I'm talking about the modern formulae,
okay,
not the earlier ones.
Sir, the formulas which can employ and measure the IOL power with the axial length, anterior chamber depth, and with the keratometry readings, we can very well use the our ultrasound biometry, sir.
Do you need to do any correction?
We'll have a correction factor based on the A constant.
No, there's a correction, there's an addition that you need to do to the axial length, because you yourself said that one measures the anatomical one and the other measures the optical one.
We have to add the retinal thickness, sir.
Yeah, so 250 microns approximately is what we add if we wish to use it with the modern day formula. Thank you.
Thank you.
Thank you.
And just one last question. When would you do the biometry? At what stage of examining the patient?
Sir, after asking about the history, basic investigations like intraocular pressure, then anterior and posterior segment examination, we can proceed with
So after posterior segment, do you mean you will perform a biometry in a dilated pupil?
it is better to do it in undilated state, sir, but
Correct.
practically, mostly we are doing it after the dilatation.
Okay. Thank you. Thank you very much. That was very, very nicely done.
Can I add one?
Congratulations.
Can I add
Yeah,
one more
please.
point?
Yeah,
And
yeah,
also
please, ma'am.
that after measuring the intraocular pressure, preferably the non-contact tonometry, not after any contact procedure. Biometry should always be done before any other contact procedure should be done. All kinds of contact procedures should be done after the biometry.
Thank you. Thank you so much, ma'am. So, do we have, I think Sir Sharmila ma'am is there, the mentor for Team Macular Goals. Ma'am is working as a senior glaucoma consultant in the Department of Glaucoma at Arvind Eye Hospital, Madurai. And she's a fantastic surgeon and has worked extensively on nanophthalmos. So, over to you, ma'am. Please, your comments.
Yeah. Thank you, Samir, for that kind introduction. And I think YOSI is doing a wonderful job by conducting all this for young postgraduates, where they can showcase their talents, and it's a platform for them to excel in whatever they do. So I congratulate all the teams for their participation, and particularly I'm mentoring the team Macular Goals with Dr. Arvind Krishna, Priyanka, and Smriti Soni. So when they took the topic itself, I was telling that this is really a tough topic. And I myself told that I might not be a really good person to mentor you in ASCAN, which has a lot of basic information. And Priyanka has done a wonderful job, though she had not answered all of the questions, but it is a learning experience. I thank the judges for bringing up all of those valid points to help her learn better. Thank you, YOSI, and I wish good luck for all the teams. Thank you.
Thank you. Thank you so much, ma'am, for your kind words. With this, we'll move on to the next topic, that is toxic anterior shock syndrome, and will be presented by Team Annulus of WIN. Team Annulus of WIN, you can start sharing your screen.
1 minute, sir. Good afternoon, all. There is something interesting happening inside this ophthalmology OT. Let's have a look inside. Here, we are having a first-year junior resident doing his first cataract surgery today, and he's being helped by an OT assistant, and there is a senior surgeon who's supervising this case. The OT assistant hands an instrument to him. Let's have a closer look at the instrument. Can you see something? Yes, there is a white debris over it. The OT assistant informs the JR about it, but the cool JR neglects it and continues with the surgery. On seeing this, the professor interrupts and asks him to stop the surgery immediately and tells him the consequences it can cause, like TASS and even endophthalmitis. The eager JR asks, "What is TASS?" The professor educates him that TASS is toxic anterior segment syndrome, which is an acute sterile inflammation of anterior segment which results from exposure of non-infectious substance, mostly during anterior segment surgeries. So let's see cataract surgery stepwise to see where all TASS can occur. First and foremost, we have sterile instruments. Yes, inadequate instrument cleaning and sterilization is the most common risk factor for TASS, along with use of enzymatic detergents and ultrasound bar. For this, the American Society of Cataract and Refractive Surgery has created a TASS task force for this. So what's the next step? It is local anesthesia. Here, endothelial toxicity is seen with preservative-free lidocaine 2%. So the safest alternative is preservative-free lidocaine 1%. So what's the next step? Staining of the anterior capsule. Any intracameral solutions and antibiotics can cause TASS by incorrect pH composition, presence of contaminants, improper mixing, dosing, or handling. Coming to our intraocular dyes like trypan blue and indocyanine green, the risk factors can be increase in time of exposure in the anterior chamber, that is more than 60 seconds, and insufficient washout. So what is the next step? It is filling the AC with OVDs. OVDs itself will cause TASS by retaining over reusable instruments and getting contaminated by heat-stable bacterial endotoxins. So the white debris in our case was retained OVD. Next we have capsulorhexis, then we have hydrodissection, nucleus delivery, cortical wash, then we have IOL placement. Yes, that will also cause TASS. IOL-induced inflammation can occur due to residual polishing compounds on the lens, solutions coating the lens, the chemicals in cleaning and sterilizing the lens, imported IOLs which is having a rougher surface, and sodium hydroxide in wet pack IOLs, and gamma radiation of the lenses. All these are seen with hydrophilic acrylic lenses. Even our powdered gloves can cause TASS. So how to identify such a case? They present with blurring of vision, mild pain, redness, initially a low IOP, then a higher IOP, and all this will occur within first 24 hours of our anterior segment surgeries. The signs are conjunctival congestion, limbal to limbal corneal edema, KPs, AC cells and flare, fibrin formation, hypopyon, iris atrophy, which will lead to fixed and dilated pupil. We can easily confuse TASS with endophthalmitis, so we should know how to differentiate them. TASS will occur early, within first 12 to 48 hours of the surgery, whereas endophthalmitis will occur 3 to 7 days. Pain is common in endo. The corneal edema is limbal to limbal in TASS, whereas variable in endophthalmitis. The hypopyon, the AC cells, and posterior segment involvement is more in endophthalmitis, and its treatment is antibiotics. The TASS is treated by steroids, and it is having a better prognosis. So how will we diagnose it? It is usually clinical diagnosis, then we have AC TAP, and then PCR. How will we manage it? It is by topical steroids, severe cases with subconjunctival steroids, oral prednisolone, intravitreal triamcinolone, topical anti-inflammatory and anti-glaucoma medications. We should know the precautions to avoid this. What are the instruments? Should be kept moist after the surgery, avoid enzymatic detergents, thorough rinsing of the instruments with deionized or distilled water after cleaning, adequate time for all the cleaning process, disposable cannulas and tubings, intraocular instruments should be cleaned separately, weekly or daily verification of the sterilizer functions, and yearly maintenance of the boilers. So here, in this case, let's dispose the cannula. So keep in mind, a patient's vision is more expensive than any ophthalmic instruments. Thank you.
Thank you so much, team analyst of in. That was really, really creative and a topic of importance because since it, many people tend to confuse it with endophthalmitis. So I'll start with Dr. Tejas sir.
Oh, great.
So
Thank you. So first of all, I would just like to inform everybody, this actually came into a lot of prominence before a year when certain a certain group of company IULs created a lot of problem countrywide. And that is the time we created a task group. And believe me, Samir, people used to say, oh, I also had a task last month. Till then, the ignorance was so much. Great that you also brought this point. Would you call it a TASS, Dr. Abil, if the patient does not have a limbal to limbal corneal edema? Is it mandatory to have a cornea to cornea limbal corneal edema? Where's the presenter?
Okay, sorry, sir.
Yeah.
Usually presents with limbal to limbal corneal edema, but if suppose only endothelium is affected, it can have patchy edema also. It is called as toxic endothelial damage syndrome.
Great. Yeah. So just to add a word, sometimes, very rarely, you might have a TASS only, and it could be it could not be a limbal to limbal. But well, I would definitely say that it is a TASS only if it is a limbal to limbal. And do you think any topical medication also can contribute? I believe you forgot to mention that.
Yes, topical antibiotics can produce, topical anesthetics can produce, like lidocaine 2%, or if we use.
Something which we definitely use in all cases.
If we apply antibiotics like.
So what do you do to what material do you paint your eyes?
Povidone.
Yeah, so we did have it in our clinic only. It was not very thoroughly clean from the eyelashes in certain patients, and probably that was the cause. But very nicely done. That was a unique way. Really, really congratulations. Over to other judges.
Thank you. Thank you so much, sir. Over to you, Ritu ma'am, for your comments.
She's muted.
So very nice concept, very nicely animated, particularly at this stage, like you're a resident and you want to understand all the concepts, all the causes, why it's happened, how does it present, how do you differentiate TASS from end of, everything very nicely, very cleanly presented and elaborated. And the differences between TASS and end of nicely pointed out, very cleanly shown that early presentation, limbus to limbus edema, and pain. I think these are the three important things which help to differentiate between TASS and ENDOF. So yeah, very nice presentation.
Thank you.
Thank you, ma'am. Anurag, sir.
I didn't get your name.
Haifa, sir. Haifa.
All right. So just a question to begin with. It's completely unacademic. Was the commentary real time, or had you pre-recorded your voice along with the running of the video?
No, sir. I did it right now. It was not recorded.
The reason why I'm asking is it's another set of skills which actually need to be congratulated and applauded. You have a very, very bright future ahead, and your voice is made for the microphone. Take it from me.
Thank you, sir.
So when we clean the instruments, there are two processes involved, as you rightly pointed out as well. One is the cleaning, the other is the sterilization. All right. So if there's any untoward event, there has to be something wrong with either of the two or both. Now I'm giving you three choices: inadequate cleaning, adequate sterilization; inadequate cleaning, inadequate sterilization; adequate cleaning, inadequate sterilization. Out of these three situations, which is the most likely to cause a TASS and which is most likely to cause ENDOF? Do you want me to run through it again?
Inadequate cleaning,
adequate sterilization, inadequate cleaning and inadequate sterilization, adequate cleaning and inadequate sterilization.
Inadequate cleaning and adequate sterilization is having more chance for TASS.
Brilliant. Brilliant. Thank you so much. No more questions.
Thank you, sir.
I would just like to mention one point here. All India Ophthalmological Society has created an adverse reaction reporting committee. So whenever you have such a unfortunate episode, please go to the website and report all your adverse reactions. It could be instrumental, it could be chemical or anything, just for the sake of information.
Thank you. Thank you so much, sir. Vinod, sir.
It was an excellent presentation, and as Dr. Anurag said, it was very visually and audio. Everything was perfect. And my question is, do you have any personal encounter with the TASS or endophthalmitis cases in your center, so that you have a proper understanding of how did you manage in your recent times?
No, sir. I didn't have it. For the good fortune.
You know, they are just residents.
No, sir. Maybe in this
they're fortunate
exposure time, I thought. Okay, thank you. That's a nice presentation.
Okay.
Thank you.
Thank you. Thank you. Thank you so much, sir. So I think we have the mentors for team analysts of IN, Dr. Jyoti and Dr. Vijayan. So can you please unmute yourself and share few words?
Yeah, I'm Dr. Jyoti. Thank you very much for the invitation to be part of this wonderful session. And as the mentor of the team Annulus of Wing, it's a proud moment for all of us at KMCT Medical College, Calicut, Kerala, to have with us our extremely talented and passionate team members, Dr. Hibba, the captain of the team, along with Dr. Haifa and Dr. Sudhi, representing us for the semi-final session. With their dedication, their creativity, and excellent teamwork, I have no doubt that they will definitely do their very best to win this competition. But what I would like to say is that it's not about winning alone. This is actually an excellent platform to showcase your talents. You have reached so far. We are really proud of you. Believe in yourself, stay focused, and do your best. All support to our team, Annulus of B. Good luck and all the very best. Also, congratulate YOSI for the wonderful initiative. Thank you all once again.
Thank you so much, ma'am. Dr. Vijayan, sir, please.
I'm Dr. Vijayan. Thank you for this excellent opportunity for the PG students of residents of Young Ophthalmologists of India. Can you hear, sir?
Yes,
Can
sir.
you hear?
Yes, sir.
So, my best wishes are for all the teams participating today. But our team, they are particularly fond of the new topics and the way in which they novel ideas. Always they have novel ideas and the novel way of presenting it. That makes them different. They are excellent students of our department, and they are always employed in newer things. Thank you.
Thank you. Thank you so much, sir and ma'am. With this, we'll move on to our next presentation, which is on capsular support devices by Team Synergist Squad.
So it's my slides are visible?
Yeah, they are visible.
Okay.
You can start.
Good afternoon, everyone. As a cataract surgeon, we must always be prepared for the unexpected. One such challenge is zonullar weakness. It can turn a routine case into a complex one. So we must have a general idea which case may present with ZD, such as soda exfoliation, hypermaturity, high myopia, trauma, homocystinuria, Morphin syndrome, etc. We must recognize the subtle signs of zonullar weakness to intervene early and have a better outcome. The preoperative findings like iridodonosis, phacodonosis, abnormal AC duct, vitreous in AC, subluxation, intraoperative findings like fluctuating AC depth, striae on capsule during capsular access, difficult hydrodissection, rotational resistance of lens, etc. In such cases, capsular support devices are very helpful, which are simple but are game changers. Simply put, they have changed many, they have saved many eyes from losing the capsular bags over the years. So what are capsular support devices? It includes capsular tension rings and segments. They are made up of PMMA. It is also known as equator ring. It was originally introduced to prevent the epithelial cell proliferation by Hara et al. In 1991. In 1994, the day-to-day CTR was introduced. It works on the principle of providing attraction, expansion, and maintaining a circular contour, capsular contour, despite the zonullar weakness. So, there are various types of CTR available in the market, but it can be generally classified into Morse's CTR. It is the most commonly used CTR. It is available in various sizes. The most commonly used is type 14C, with the diameter of 11 to 13 mm. It is used for normal eyes of axial length 24 to 25 mm. Next comes the Chionis CTR. It's a special type of CTR for scleral fixation, can be used for moderate ZD. It is this is another version of Chionis CTR. Henderson CTR is a specially designed sinusoid-shaped CTR. With these indentation, the capsular walls become easier. Ahmed's capsular tension segment. It is a partial ring of Chionis CTR. It can be used separately or together with the CTR. It covers approximately 1 quadrant. It can be used temporarily or for permanent fixation. So what are the contraindications? the anterior capsular tear, posterior capsular tear. In such cases, capsular tension segments can be used. Subluxation more than 7 o'clock hours. In such case, we can only go for whole back removal followed by anterior vitrectomy with scleral fixation of IOL or anterior chamber IOL. So what stage do we need to insert? It can be inserted before the nucleus removal or after. So before nucleus removal, it makes the surgery safer and early stabilization of capsular bag, but the disadvantage is the cortex aspiration becomes very difficult. After nucleus removal, the cortex aspiration is very easy, but it can be only used in such cases of mild zonular weakness. The insertion of capsular tension segment in this pre-cut scleral window is made, and the CTR segment is placed fixed with the proline suture in that weakness area, and the IOL can be placed. So how do we insert a CTR? There are various techniques available, but it can be grossly classified into the manual insertion, as you see in this video, and with the help of an injector, as you seen in previous videos. So what are the benefits of CTR? It stabilizes the generalized weakness and localized zonular dehiscence. It also reduces the risk of posterior capsular rupture, vitreous loss, lens tilt and decentration, and it also prevents early opacification. The potential complication include improper placement in it may be in anterior chamber or sulcus. In such cases, it is difficult to retrieve it back, and late dislocation in case of progressive zonulopathy. These are my reference. Thank you.
Thank you so much, Dr. Vinita from the team Synergist Squad. I would like to invite Dr. Anurag sir for his comments and questions.
Again, I didn't get your name.
I'm Vinita, sir.
Okay, Vinita. Very nice, very nice. But I probably would have loved to see the last minute and a half dedicated to the capsular hooks as well, because they are also an essential capsular support device. The reason for that is when you're implanting a CTR, you're just giving a horizontal support to the back. You sometimes need a vertical support. I think you showed one of Haripriya ma'am's videos where she is actually using both.
Yes, sir.
Yeah. So tell me something. This is a question for you. You talked about sizes, but how to put in the CTR is something, I mean, the modalities might be manual or through an injector, but how to put it into the bag is where the crux lies. Say you have a zonular dialysis from 6 to 8 o'clock or 6 to 9 o'clock. 6 to 9 o'clock. How would you put the CTR then? That's number one. Number two, despite of all your attempts, should the CTR attempt to skip into the sulcus, how would you identify that?
Sir, in case of if the weakness is in the area of 6 to 9, we will go to the opposite from temporally.
Right.
Sir, we shouldn't enter in the area of weakness. If it is so, it may increases the weakness. Zonal ZT will be increased and the locus will be increased. So we'll usually go by the opposite direction. So we will insert in that area, like around 3 o'clock.
Okay. Question number two.
So we will insert with McPherson's and we will dial with Sensky hooks.
Okay. The second question, how will you know that it's gotten into the sulcus? Did you see,
of the CTR?
go and watch your own videos while they are being inserted. You will see the forwarding or the advancing eyelet while it is encircling all around the bag.
Yes, sir.
Okay, that will give you a clue to the answer to my question, second question. And the first question's answer is partially right, but the other thing is when you are trying to support the equator or stretching the equator, the maximum stretch is exerted at an area which is opposite the point where the two eyelids meet. So when you are implanting it in the opposite quadrant, the site that's opposite to it would be where the stretch is maximally exerted. So that's the reason why you should actually start inserting it bang opposite the area where the dialysis is there. Thank you. Nicely done.
Thanks.
Thank you so much, sir. Vinod, sir.
It was a nice presentation. The most key factor point is when to put the CTR. Sometimes if you find the bag is very weak, so what will be a situation? Whether you'll be putting it once your excess is done or you will do your cataract extraction and then when will you put the CTR? When will you, the time of call to put the CTR? So what will be a which position before emulsifying the nucleus? Or you, because sometimes if the peaks are for some very complicated cases, I suggest to put a CTR and then do the phaco. So what will be a, which step you want to preferably you put the CTR if it is a very weak bag. So because you told if you put a CTR, it is difficult for the cortex wash. So what will be a choice of step to insert the CTR in a very weak bag or which on such condition, PX of such conditions?
In such weak bags, it's better to insert earlier, sir, before phaco. Because in if it is 3 to 5 clockers or more, if more than 3 clockers, it's better to insert before phaco to have a better stabilization of the bag.
Yeah.
So while doing a nucleus manipulation, it will be little safer.
Yeah, okay, fine. Thank you.
Thank you so much, sir. Dr. Ritu, ma'am.
Nice, clear presentation. Facts very well stated. Just one quick short question, which is tell me one absolute contraindication where you would not consider putting a CTR. One thing which you would just cross check before putting a CTR. What would you see in the bag? What would you like to ensure before putting a CTR?
There must not be any capsule tear or rupture, ma'am. Then if it is so, then we can consider capsule segment tension segments if it is in little small pieces, and if it is subluxation or more than 7 clockers, if it is a very gross zonal weakness, we shouldn't consider CTRs.
There should not be any tear in the rexus and the posterior capsule should be intact.
Nice.
Otherwise,
Yeah. Capsular excess should also be intact.
Otherwise, the centrifugal forces of the device will eventually, compromise the bag. Thank you.
Thank you, ma'am. Tejas, sir.
Well, you mentioned a lot of difficult situations where you would implant a CTR. Would you implant a CTR in a normal condition also? If so, which are those? Where the anterior capsule and the posterior capsule is still intact, there is no zonular dialysis, and you would still want to implant a CTR. What are those conditions?
If we anticipate any bag weakness or zonal weakness in the future, in such cases like in pseudo exfoliation, dense pseudo exfoliation, even if we're not able to visualize, it's better to safe and sorry, so better insert CTR for safer side. Thanks.
Great. And are you aware of some surgeons implanting a CTR in high myopes too?
Yes, sir.
Okay, great. And like Anurag did mention, you can definitely talk about the capsule supports with the hooks also. You could have squeezed in more information, but your first 1.5 minutes was kind of not actually coming to the topic. Otherwise, you could have still squeezed in a lot of more information, but it was still brilliantly done. Excellent.
Thank you, sir. Thank you.
Thank you so much, sir. So with this, we'll move on to the last seminar, which is on management of intraoperative complications of cataract by the team Sight Seekers.
Good afternoon, sir.
Yeah, it's visible. You can put it in slideshow and you can start.
Yes, sir. Once. Surgery is not about perfection. It is about preparation, anticipation, and calm in the face of chaos. Good afternoon, everyone. We are Sight Seekers from King George Medical College, and today we dive into the crucial domain of intraoperative complications, which are not merely challenges to overcome, but opportunities to demonstrate the true essence of surgical composure, judgment, and precision. Every cataract surgery follows a familiar route from incision to wound closure, but we should remember that every bend along that road carries potential detours in the form of complications. From a trivial subconjunctival hemorrhage to the shaky foundation of an incompetent wound, complications can lift his demonic head in the form of a prolapsing iris, incomplete capsulorhexis, zonular dehiscence, or nucleus drop, each having a significant effect on our final visual outcome and IOL placement. If cataract surgery is our battlefield, then posterior capsular rent is the adversary every surgeon hopes never to meet, but must always be ready for. It is a turning point that defines what follows next in surgery, disaster or redemption. PCR doesn't ask for permission, does not follow a schedule. It can strike at any stage and at any time. It can be when we are doing capsulorhexis, where a sudden tear extension beyond the equator can also involve the posterior capsule, or forceful injection of fluid can lead to a capsular blowout. Direct trauma or removal of cortical matter aggressively can also lead to a posterior capsular rent. So, how do we manage it? The first step shall always be recognize the rent. Stop, breathe, and reassess the situation. The eye often speaks before the rent is obvious. Therefore, signs such as pupillary snap sign should always be looked for because ominous things might be waiting ahead. The primary aim should always be to have a clear media and to place the IOL that we have decided. Posterior capsular rent once identified, then we should look for if the anterior hyaloid phase has been disturbed or not. If not, and the nucleus is in the bag, make OVDs your best friend. Maintain the anterior chamber, manage the nucleus, and dry aspirate the lens material. If vitreous has come into the bag, then bimanual anterior vitrectomy needs to be done. If there is a nucleus drop, clear the AC and refer to a VAR surgeon. Do not take any risks. Then make sure the wound is closed properly. If required, put a suture. Placement of an IOL entirely depends on the surgical scenario that is present at that time. Whether you can put the IOL in the bag, in the sulcus, or a secondary IOL is required, all depends on what is happening at that current time. The iris is our ally, but sometimes that can also behave unruly. It can prolapse through a leaky wound, or it may obstruct the phaco tip or aspiration port. Who knew that treatment for a trickling bladder can make an ophthalmic surgeon's life difficult? Intraoperative floppy iris syndrome due to alpha adrenergic antagonists can lead to iris billowing, progressive pupillary construction, and iris prolapse intraoperatively. The management starts from wound construction. For phaco, triplanar wound needs to be made. Judicial use of OVD has to be done. Intracameral epinephrine can be used, and proper closure of wound at the end of the surgery is always required. One of the thinnest layers that makes the loudest statement, descemet membrane detachment, can also occur at any stage of the surgery, even while introducing an instrument into the AC. Prompt recognition and gentle handling are key. Small detachments may resolve spontaneously, whereas larger ones require an air tamponade or viscoelastic. As we near the end of the surgery and we are confident that we are going to place an IOL, lo and behold, the IOL may also be a betrayer. A broken haptic or a cracked optic or IOL decentration can also complicate a surgeon's life. The best way is to place a new IOL or reposition the decentered IOL with dialing instruments. As we come to an end, let us talk about suprachoroidal hemorrhage, a silent threat until it becomes a dreaded intraoperative complication. It is sudden and requires us not to panic. Look at the signs, identify it, and manage the case. Always remember, each surgery is a continuous education. Embrace the challenges, learn, adapt, and thrive, because it is not the smooth cases, but the stormy ones that define us as surgeons. Thank you.
Thank you, team Site Seekers. So I'll start with Dr. Ritu ma'am. Ritu ma'am. Ma'am, are you there? Okay. Dr. Tejas, sir.
Okay. Excellent. That was a nice way of presentation. And basically, that was too broad a topic to be covered in 5 minutes, but you still did a good job.
Thank you, sir.
Have you also ever encountered a lost IUL?
Yes, sir. It has been.
Or a split injector, or the IUL opening the wrong way? I would
Yes.
not blame you for not including, because that was too much. But keep that also in mind.
Yes, sir.
And what is the most dreaded complication that could happen, especially you are in an institute, right?
Yes, sir.
What is the most dreaded complication?
Sir, according to me, something that always worries the surgeon is a posterior capsular rent, as well as something that is, if the IOL is lost or the IOL has dropped, that is another thing that bothers us. And something that is sight threatening could be a suprachoroidal hemorrhage that we should always be on the lookout for.
And one more?
And,
I said most dreaded. And of course, sight threatening. You almost lose your sight almost every time.
Sir,
Expulsive hemorrhage.
Expulsive.
Don't want to scare you.
Yes.
Okay, great. And in an institute, sometimes has it happened? You operated the wrong eye. That is also a complication.
Yes, sir.
Great. Over to some other judge, please.
Thank you. Thank you, sir. Vinod, sir.
That was an excellent presentation. Almost everything was covered. And the most important things, as she mentioned, suturing the wound post PCR, because that could be contribute to the endophthalmitis, and the IOL haptic wrongly opening, everything was covered. I think he has covered everything in 5 minutes. Such a wide topic, and it was a good job.
Thank you so much, sir.
Thank you.
Thank you. Thank you so much, sir. Dr. Anurag, sir.
Very poetic. I think, do you write by any chance?
Yes, sir. A little.
It was evident. It was evident.
Thank you, sir.
Tell me something. These are all residents, the presenters, all of them?
Yes. They're not more than second year or third year, I believe.
Second year or third year residents?
Yeah, no senior residents also allowed.
Okay, give us an alarm bell the moment you are all set to set your foot on the bigger stage, because we'll all retire. I think you are anyways going to be toppling us. So before that, we'll just save our dignity and walk out of the presentation arena. Nothing to ask a question, as everybody has rightly pointed out. It's too vast a topic, and no one question can be asked. Although there is a comment, and I would have perhaps liked to see a particular order of the complications. Either you start from the cornea and go to the posterior capsule and then on, or else you divide them into the the more salvageable to the less salvageable conditions. So, as we move on up the ladder, the incidence of these things keep on reducing. What it would have done is, you encompassed a lot of conditions, but the only thing that was left out and should have been at least a mention, an honorable mention, is the anterior capsular giveaway. That's something we encounter very, very commonly. It's much more common than the attachment at the wound. So that gets missed if you do not
Yes.
have the structures in mind and arrange them in a step ladder fashion. That's the only comment I wanted to make. Otherwise, very, very well done indeed. Thank you.
Thank you so much, sir. I'll keep in mind for the next time. Thank you so much.
Anurag, I believe she did start with the wound and then with the
She
descent.
started with the PCR, sir.
No, I think she started with the wound and the iris prolapse.
Yes, sir. In the beginning, I had highlighted all the things that can go wrong at
That
each
is fine, but the
No,
description.
we are not fighting. We are not fighting.
Yes.
Great. Move on.
Thank you so much, sir.
I think
Ritu
Dr.
ma'am.
Ritu has joined back, yeah.
Ma'am, you are muted.
Muted, Dr. Ritu.
So as I totally agree with what sir said, that it would have been great if there would have been an order of presentation of the complications, whether in an anatomical manner or the order of occurrence. Just one quick question. What would you suspect if you see that the patient on day one had a paracentral corneal edema going up to the main port? What would you suspect?
A paracentral corneal edema going up to the main port. So, ma'am, it could be various things. Either while aspirating the nucleus, there was a lot of power that was given. So there is a surgical trauma that has occurred to the endothelium, or high intraocular pressure that could have retained viscoelastic that is present in the AC that has not been removed. Whether it's a tight wound or the sutures are too tight. Thing.
No.
You look for Descemet's membrane.
You spoke about that, lady.
Yes. Thank you.
Thank you so much, ma'am. So I think we have the mentor for team site seekers, Dr. Arun Kumar Sharma. Sir, over to you for your comments.
Yes, it is a very vast topic, although they have covered it nicely. So best of wishes to the team science. Thank you.
Thank you
so much, sir, and thank you, team.
Yes, sir. Thank you, sir. Thank you to our mentors who have allowed us to use their surgical experience, Professor Gupta and Professor Sharma, sir. Thank you so much.
Thank you so much. With this, we are done with the first round, and I would like to invite Dr. Roma to conduct the second round, Pupils Got Talent. Over to you, ma'am.
Okay, so we'll move ahead and we'll go for the second round, which is Pupils Got Talent. In this, team members will be given time, and they have to present in the form of reel, music, dance, art form, and 20 marks will be awarded for this, and topic is cataract. So the first team who's presenting is Optic Oracles.
अरे नानी, मैंने आपको रील भेजी थी, आपने देखी?
अरे क्या बताऊं, मुझे ढंग से दिखता ही नहीं है।
क्यों, क्या हुआ? चश्मे का नंबर बदला है क्या?
डॉक्टर ने बोला तो था मोतियाबिंद है, लेकिन अभी जब दिख रहा है तो ऑपरेशन क्यों ही करवाऊं मैं? पक्का थोड़ी ना है अभी।
अरे नानी, अपनी डॉक्टर बेटी से तो पूछ लेते। यही तो गलती है, आजकल मोतियाबिंद को आना नहीं होता है। पके हुए मोतियाबिंद का ऑपरेशन भी मुश्किल होती है और साथ में उसके रिजल्ट्स भी उतने अच्छे नहीं होते। पके हुए मोतियाबिंद के कारण कॉम्प्लिकेशंस भी हो सकते हैं, जैसे काला पानी। इसीलिए टाइम से ही ऑपरेशन करा लेना चाहिए।
शर्मा जी ने बोला था कि आई ड्रॉप से ही ठीक हो जाएगा, उनके पहले मम्मी ने भी ऐसे कराया था।
अरे नानी, ये भी गलत है। अभी तक ऐसी कोई दवाई नहीं बनी है जिससे मोतियाबिंद ठीक हो जाए। इसके लिए इकलौता और परमानेंट इलाज सर्जरी ही है, तो इसके लिए ऑपरेशन ही कराना पड़ता है।
अरे बेटा, ऑपरेशन में दर्द भी कितना होगा। मैं 1 महीने तक बाल भी नहीं धो पाऊंगी और फोन भी नहीं चला पाऊंगी, टीवी भी नहीं देख सकती।
नानी, आज तो टेक्नोलॉजी इतनी बढ़ गई है कि बिना किसी सुई, बिना किसी टाके और बिना किसी दर्द के 10 से 15 मिनट में ही ऑपरेशन हो जाता है। आपको पता भी नहीं चलेगा और 2 या 3 दिन में ही आपकी रोशनी एकदम बढ़िया हो जाएगी।
अरे बेटा, अभी बारिश का मौसम चल रहा है, मोतियाबिंद का ऑपरेशन तो सर्दियों में होता है ना।
मौसम से मोतियाबिंद के ऑपरेशन का कुछ भी लेना देना नहीं है। ऑपरेशन के रिजल्ट इस पर निर्धारित हैं कि आप कितनी केयर करते हो और कितनी सफाई से रहते हो, और वो चीज आपको हर मौसम में करनी पड़ेगी। तो ऐसा नहीं है कि सर्दियों में ही ऑपरेशन कराते हैं, ऑपरेशन आप किसी भी सीजन में करा सकते हो। In this age of Google and WhatsApp forwards, it's easy to get lost in misinformation. But when it comes to your eyes, don't rely on myths, rely on your ophthalmologist.
Wow, very impressive cataract awareness video. Over to you, judges, for your comment, please. I'll request Dr. Vinod, sir. Sir, are you there?
Yeah, I'm there. I think I won't be able to comment because it's in Hindi. I just saw the subtitles. I don't understand Hindi. I think maybe the other judges would.
Sure, I'll request Dr. Ritu, ma'am.
Right. So nice concept. All the common points, all the common myths which the patient asked you or the patient has related to cataract surgery, they're all covered. Like the patient will say, give us some drops to arrest the progression of cataract surgery, the season-related beliefs of the patient, and whether they should wait for the cataract to mature, and all those small points which we normally encounter in clinics, they will covered. So nice concept.
Okay, thank you, ma'am. Dr. Tejas, sir, you want to comment on something?
Yeah, as always. Well, I'm so very happy that they did not go overboard and talk about robotic cataracts because this was for general public, and I believe this was definitely a lot of concepts covered. I don't think I have any more comments to make at this moment. Thank you.
Dr. Anurag, sir?
Yeah, I don't know. I mean, how have you designed this? Is this something that's does it necessarily have to have a social message, or is it something that can have technical content as well? I'm just asking for my curiosity.
It's just for the awareness, I think they have.
Okay, all right.
It's awareness or creativity too, I believe.
Content creativity.
So Anurag, I believe, it could be a message, it could be some information. Well,
I believe
for the layman or for the colleagues also, it could be, right? I'm not sure. Let's see all the four other, and then we'll be able to actually find out.
No, but what's the formulation? Because we have to award marks to this.
Yeah, that's going to be difficult.
Just asking, what is it related to? The creativity, it should be made with creativity. I'm so sorry I couldn't get the clarification earlier because I thought it to be something else. But is it creativity that necessarily gives a message to the society?
Yes, sir. There are marks for creativity as well as for the content and the message they are reflecting. So there are different marks. We have given you the mark sheet in that the subcategory.
I have it on me. Yeah.
Yes,
all
sir.
right. Fine. Thank you. Very well done.
Roma, is it necessarily for the public or just like a message to other colleagues also?
It can be a message to other colleagues also, sir.
Great. Yeah. So it could be a topic and they might have, let the things unfold. Great.
Yeah, but the only comment is the Dadi was not actually looking like a Dadi. So get your...
that was the creativity you have to have, Anurag. Imagine her to be a Dadi. Okay.
I'm ready to be your model the next time you do it, because Dada can also be explained about the essence of cataract surgery.
So we'll move on to the next team presentation, macular goals.
Hey there, welcome to Vision Vigilante News. Today's hot take, cataract myths. We have with us today our special guest, our mythbuster, Dr. AK.
Doctor, you said I don't need glasses after surgery. There is an advertisement outside saying goodbye to spectacles. Now, you are asking me to wear near vision glasses. I am a joke to you?
Sir, calm down. You have opted for monofocal intraocular lenses. These lenses do not have the same accommodating power as like your normal lenses. Hence, you will be needing glasses for near vision.
Blurry vision and I can't see. Let's see what WebMD has to say. It says I have cataract. Me? At 27?
Hello, my little minions. Just guess what? Your favorite influencer has been diagnosed with something called cataract. I'm not dying, it's not a pimple, but it's still something. What is going to happen to me?
Young people can get cataracts as well. Various factors like diabetes, trauma, steroid usage can definitely cause cataracts in the young. So Gen Z, don't think you're immune to cataracts.
Hey, come here. I'll tell you one secret. This eye drops, no, made of cow's tears. If you put in eyes, no, all the cataract will go. I gave to my neighbor, all the cataract went. Here, use.
Madam. The only thing that's going to vanish if you keep buying those drops is your hard-earned money. Cataracts are opacifications of your natural lens, and the only treatment available in the world right now is surgery.
Wow, very impressive. Breaking news. So the cataract is caught red-handed. Over to you, judges. Vinod sir, you'd like to comment?
Yeah, it was a nice factors they covered. All the myths has been busted, and it was like a new Instagram trend. They have made it very nicely, very eye-catching and attractive. It was a good presentation.
Thank you, sir. Anurag sir?
Yeah, so heartening to see the first male presenter of the day without any gender bias. That's a disclaimer. I'm not someone who does that. And so heartening to learn that for ladies or females, it's either cataract or pimples that bother them. There's nothing else that bothers them as much. Very, very nicely done. I would definitely subscribe to your channel. I know that's a false name given, but if you ever have a true channel or handle on Instagram, do let me know. I'll definitely subscribe to it. Thank you.
Thank you, sir. Ritu ma'am?
Yeah, nice video. But I think the same concept which was shown in the first by the first team, the optic articles, content was more or less same. The creativity was very, very good.
And they were not aware of each other's videos.
Right.
So
Yeah.
Yeah, correct.
Yes, Tejas sir, any comment?
Yeah, so the lady influencer, she mentioned her age. I was so surprised. She said that she's 27. Yeah, this was a nice way of presenting, and I believe they get a lot of marks for that creativity and the content both. Thank you.
Okay. Thank you, sir. We'll move to the next presentation by team Annulus of Ben.
These glasses are of no use. I don't even know if it's Gukesh or Magnus who won.
Don't blame the glasses, Grandma. It's because you didn't have my special morning tea.
No, it's still blurry. And it's been like this for the past 6 months, dear.
Okay, chill, Grandma. Let me ask the GPT buyer about this.
Blurry vision may be due to serious conditions like glaucoma, macular degeneration, retinoblastoma, or even brain tumors. Seek immediate medical help.
Brain tumor? You can't just sit here sipping chai. We have to go to the doctor now.
If I die, I'm taking you with me. There is no sugar in this tea.
So what Grandma has is a very common condition called cataract, and it's treatable.
So she's not having retinoblastoma or macular degeneration?
No, cataract is a condition where the lens inside your eyes gets cloudy, mostly due to aging.
So will it get cured by eye drops?
Not exactly. If it's affecting vision, then we must do surgery.
Surgery? Won't it be painful?
No, we will pour eye drops to make it painless.
So do we need to take 1 month rest?
No, you can actually go home the same day itself.
So ChatGPT was wrong? It was just treatable cataract?
Yes, even though platforms like Google and ChatGPT are helpful for us, can we rely on them for all our medical issues? No. Get your eyes checked for cataract today.
And by one day,
your grandma can live her life the 4K way.
Wow, very nice, mind-blowing. still showing that AI is still intern in giving the differential and actual boss is your doctor. So yes, ma'am, we'll move to the judges. Ritu ma'am.
The first part of the video was quite entertaining. The grandmother is concerned about sugar in the tea, and the granddaughter is just worried with brain tumor and retinoblastoma. And yeah, the second part of the video showed all the myths which the patient had related to cataract surgery. So overall, nice combination.
Thank you, ma'am. Tejas sir.
Well, very super creativity, especially with Gukesh and Magnus and the chess board and the questions and answers. Awesome. Just awesome. Thank you.
Vinod sir.
Yeah, it was very nicely made, and the tagline which they ended in "See a grandma with the 4K way." So all the dialogues which they used also very catchy and nice. Nice presentation.
Okay, thank you, sir. Dr. Anurag sir.
Yeah, for the first time we saw some theatrics into it. So theatrics always make things more interesting. I love the chessboard war between three people there, and the advances, the moves they've been making, and the parallel drawn to Gukesh and Magnus's famous match. So, and the last part wherein she actually emulated Gukesh's reactions after he had won that game was absolutely brilliant. I think that's the best way one could have ended it. Thank you so much. It was really well done.
Thank you, sir. We'll move to the next presentation now. Team Synergist Square.
The lens helps us see clearly by focusing light.
But what if that lens goes cloudy when you're not home? Let me tell you a tale, child.
A young food vlogger, Ravi, develops cataract due to his diabetes.
He ignored his diabetes. Now his world looks like this. This grandmother uses steroids for joint pain for years without monitoring. Her vision fades despite never aging. This teen boy, hit by a ball, developed cataract. One injury, one silent cloud. Mina, with red eyes, sees her lens slowly clouding until treated. Her own body caused inflammation, and the fog followed. Listen well, my young minds and old hearts. Cataracts don't just come with age. Cataracts come in many forms. Diabetes, steroids, trauma, inflammation. The cloud may not wait for old age to strike. Catch them early. Treat them right.
Wow, beautiful, like grandmom's fairy tale. Over to you, Ritu ma'am.
Yeah, so I really like the videos and that fairy tale and all that. And the video had little more scientific content, like they showed the causes of the cataract. So that was good.
Tejas sir.
Yeah, like Dr. Ritu mentioned, they really covered two more and two very important. One is steroid and the injury. So I believe that was slightly beyond and better than other causes that were mentioned in the previous videos. But they also mentioned very nicely the inflammation, which was the uveitis or something. That's what they were trying to convince, that sometimes it could be our own body responsible for the cataract. Really, really creativity. It's to its best. Congratulations. Yeah.
Dr. Anurag sir.
Yeah, I love the voice. I think it was AI, if I'm not wrong, that has delivered this voice. Am I right? The team?
Yes, sir.
All right. But forgive me for saying this, but I would slightly disagree and differ from the earlier two judges. The messages are of two types. One has to be for the society, one has to be for your colleagues or fellow professionals who are practicing ophthalmology. This was actually something in between, because you don't need to tell an ophthalmologist that inflammation causes cataract, and the general public will not even understand what inflammation is. So it has to be depicted in very, very simple and plain language. cataract has many causes other than age is fine. But what are those causes? The task is up to you to make them understand. Diabetes is something people will understand. Steroids is what people not understand. They're being treated for rheumatoid arthritis, all they know. Whether it's methotrexate or steroids is something they don't know. So I would just disagree, and I would just think that you must have one lineage along which you carry yourself along while giving a message. Either it is for the public, wherein it has to be very, very simple, or it has to be for your fellow colleagues, wherein it has to be absolutely technical. The middle mingling thing is something I do have a little bit of an issue with, but however, the articulation and the way the flow went was absolutely spectacular. I must say that. Congratulations to you.
Thank you, sir.
Can I beg to differ on what Anurag differed?
Yes, sir. Myself.
Yeah. So I think, Anurag, it was very, very subtly mentioned about the inflammation. And well, you have to understand that sometimes a cataract can be because of your own reasons like endogenous reasons. And steroids, I'll tell you what, every second patient or probably all patients in my prescription, sir, isme steroid to nahi hai na? There is no steroid. So I believe that is also a very, very common thing. And inflammation, I was impressed. Well, they did not be an ordinary, just to not to mention uveitis. They did it very well. To me, full marks. Thank you.
Thank you,
But
sir.
in my part of the world, they don't know what steroids are. I mean, I'm
Really?
a rural practitioner.
They only know God.
I think Dr. Vineet was left.
Yes, sir. Dr. Vinu, sir, you'd like to comment on?
My point of comment was where it was scientifically, I mean, theoretically, everything was covered. There was no hook point. Where nowadays Instagram, when we're scrolling, within 3 seconds we have to go for the next reel. So if I was seeing this reel, I would scroll. There was no hook point for this reel. Rather than the other two videos where there was some interesting point, entertainment point of view was there. As we see in movies, like a Shah Rukh Khan movie, it is more entertaining than a documentary movie. I feel this was more like a documentary side. Content was good, but that was more entertaining. So that's why, and this, as Dr. Anurag said, the steroids, everything that your public won't understand. So that I go with Anurag for this point of view, his point of view. I support him.
Okay, thank you so much, sir. We'll move on to our next presentation of Sight Seekers.
अरे अम्मा क्या तुम इस उम्र में बेद पढ़ रहा हो?
अरे का बताए बबुआ, ना परिवार है ना कुछ, हमको दिखाना है, पेखाना पेशाब करना भी दुश्वार हो गया है। अब महादेव बस हमका उठा ले।
अरे अम्मा क्या तुम इस उम्र में मरने की बात कर दो? चलो तुम्हें अस्पताल में दिखा रहे।
ठीक है बबुआ, चलो। ऋतिक प्लीज, आज तुम्हें मेरी बात सुननी पड़ेगी। I don't care. My baby doesn't even look at me. And I'm pretty it's not normal, Hrithik. I've read about it, I've researched, and I'm pretty sure I see something white in his eyes. We need to take him to a doctor.
Okay, fine. कल चले?
Yes. ये लेक्चर कभी खत्म ही नहीं होते।
चल यार घूम के आते हैं। मैं अपने सनग्लासेस ले आऊंगा।
इतनी कोई धूप नहीं है, क्या ड्रामा कर रहा है?
यार मुझे बाहर ऐसे ना चकाचौंध और ग्लेयर होती है, मुझे लगाने पड़ते हैं।
Strange. क्या पी रहा है मुझे भी दे?
प्रोटीन है।
प्रोटीन? अच्छा। कब से पी रहा है ये?
सालों हो गए।
अरे भैया, इसमें स्टेरॉइड है। यही बताता तुझे ये सिम्टम्स क्यों हो रहे हैं। चल आज एक सीनियर को दिखाती हूँ।
तुम आजकल बड़े परेशान कर रहे हो।
हाँ यार, 2 महीने पहले मुझे चोट लगी थी और उस वक्त तो कुछ पता नहीं चला था, बट उसके बाद से अब धीरे धीरे धुंधला ही दिख रहा है।
Sounds very sad. मैं तुमको मेडिकल कॉलेज लेके चलता हूँ।
ठीक है।
कल की ओटी लिस्ट में तो काफी वैरायटी है डॉक्टर अनुषा। आप सभी की जांच कंप्लीट हो गई है, आप लोगों को मोतिया मिल गया है। क्या?
हमारा तो इतना छोटी बेबी है।
ऋतिक, मैंने बोला था ना पहले लेके आना था इसे।
उससे इतनी बड़ी गलती होने वाली थी। ये तो बूढ़ों की बीमारी है।
कैटरैक्ट, माय करियर इज ओवर।
यही तो गलत फहमी है। बुढ़ा हो या बच्चा, अमीर हो या गरीब, हेल्दी हो या सिक, मोतियाबिंद किसी को भी हो सकता है। ये एक साइलेंट इन्वेडर है जो हमारी रोशनी छीन सकता है। इंडिया में मोतियाबिंद अंधेपन का बहुत ही मुख्य कारण है, लेकिन अच्छी बात यह है कि इसका इलाज संभव है। आज मेडिकल साइंस ने इतनी तरक्की कर ली है कि कुछ मिनटों के ऑपरेशन में ही रोशनी को बहाल किया जा सकता है। आंखें केवल देखती नहीं, भावों की है खान, धुंध हटे जो मोतिया की, दिखे सारा जहान।
Wow, nice presentation. So, Dr. Anurag sir, any comment?
Yeah, very nice. Very nice. This is the kind of blend that I mean, everybody would wish to see. It had something in it for everybody. Very, very nicely done indeed. There's just one section where the two people sitting on the chairs talking, we couldn't catch the audio properly. That could have improved slightly. You can use the lapel or the collar stud microphones or even the earbuds that work very well with the phones when you're catching the audio. But apart from that, the editing, the articulation, the flow, everything, and even the shout out at the end, everything was picture perfect. Thank you so much. Very nicely done.
Thank you, sir. Over to you, Ritu ma'am.
Yeah, good compilation of the hospital background and everyone coming in the end and seeing that message. It was a good thing.
Thank you, ma'am. Tejas sir.
Yeah. So there is very little to separate between all these 4 videos. They all did kind of nearly the same job in a different manner. But I really loved the last 2 sentences. Budhe ho ya bache, amir ho ya jawan, whatever that was really very well made. Super. And ROP also was very nicely brought out.
Thank you, sir.
It had a message in it for us too, sir. We should also get our eyes checked because we're also senile. So thank you so much for letting us know, poking us. I'll do that tomorrow.
Come to Ahmedabad.
Vinod sir,
Too
comment
expensive.
from you.
Oh, it was a good presentation. Everything was nice.
Thank you, sir.
Thank you, sir. Thank you so much.
Now over to Mosri ma'am. Thank you, judges and mentors, for your valuable insights and feedbacks. Mosri ma'am, are you there?
Yeah, sorry, I was muted. Yeah, okay. Just 1 second. I'll just share. So would like to thank our judges and mentors to spare 2 hours of Sunday and to give their valuable inputs. So we'll just present the certificates to the judges before we go forward with round 3 and round 4. Judges are more than welcome to stay if they want because more entertainment is left for them. So thank you, Dr. Tejas sir, for your time and all the valuable inputs you have given today to the
That's an
judges.
awesome certificate. And I'm really surprised the judge getting a certificate, but I really love the concept. Thank you.
Okay. Dr. Ritu ma'am, thank you ma'am for giving your time today and all the inputs you gave today.
Thank you, Mosmi. Thank you. We had a really great time.
Thank you, ma'am. Dr. Anurag sir, thank you that you showed so much of interest and you were so passionate in teaching them also. Thank you, sir.
Yeah, Sunday well spent, I must say. The one of the rarest things that has attracted me more than my OT on a Sunday. Thank you so much for making me a part of it.
That's very kind of you, sir. And Dr. Vinod sir, thank you so much that you spared 2 hours today on a lazy Sunday.
Thank you. Thank you so much. Thank you, YOSI, for the opportunity.
Thank you, sir. So we'll just take a photo, all of us together. So we'd like all the participants also to switch on your videos, please.
वीडियो तो ऑन करे वो Alt V. अरे okay.
Who's going to take the snapshot? Dr.
I'll take.
Yeah, okay, fine.
We
क्यों नहीं आ
can't
रहे?
see the site seekers. I think you have an issue with, please switch off your virtual background. I don't think we can see you. There's
Okay, sir.
color profiling is not being maintained by your camera properly, so you can just get rid of that.
HD video.
No, the virtual background, just remove the virtual background. Go
Done.
to video settings.
Yes, sir.
We still can't see you.
The camera is on also. It's video. It's
And while you're figuring it out, please mute yourself. You
Yes,
don't
sir.
want to. Yeah.
Site seekers, you can log in from any other device if it's possible. Okay, so shall we take the photo, Dr. Samir? Okay. So we'll Yeah. We'll make the iconic YOSI V for victory. Okay, is it done? Yeah, okay. Thank you so much once again. Thank you, sir. Thank you, ma'am. And also thank you all the mentors to support your teams.
Just a quick question before you go to the next round. Should we share the score sheet on the group?
Yes, sir. You can share it with us in the group. Thank you. Thank you.
Thank you.
Dr. Samir, over to you for the next.
Yeah, thank you so much. Thank you to all the judges, and thank you, Roma ma'am, Mosami ma'am, for the for conducting it till now. So we'll move on to the next round, round 3, which is knowledge nexus. Guess what? So I'll read out the instructions. So all teams will play together. It is more of a rapid fire. So each question will be flashed for 20 seconds. If you know the answer, type your team number in the chat box. You will be asked to unmute and answer. There will be 4 questions in total, and marks distribution is as follows. So you'll be provided with a hint in the first as soon as the question is the question will be the first hint. So if you answer it correctly, you'll be given 20 marks. And if you answer it incorrectly, remember there will be an equal negative marking as well. So if you're not able to answer the first question, it will proceed on further. Okay, there will be no further guesses on the same hint, and the second hint will be further projected, and then you can answer again. The same team can answer it again as well can other teams. So after each hint, we will be typing XXXX in the chat box so that it resets. So please don't answer or type your team number before the next hint is projected. We'll have 3 audience questions in between, and please remember your order number. Team 1 will be optic oracles, 2 macular goals, 3 annulus of wind, 4 synergistic squad, and team 5 will be sight seekers. So please type your team number in the chat box. Okay, so we'll move on with the trial question. So a trial round. This actor from Bollywood with a famous surname made his acting debut in 2012 with an action romance movie. So the teams can answer their team number. Whosoever wants to answer can answer their team number in the chat box, and the first one will be answering the question. So Roma ma'am.
So team 3 is the one. Yeah, team 3.
Okay, so team 3 can unmute and answer.
Asking Sir Tiger Shroff.
Okay. So can you move on, ma?
Yeah.
I think Tiger Shroff is not the correct answer.
Yeah, it's wrong. So we'll go to the
Yeah,
hint.
yeah. So
We'll go to the
in
next.
case so if it was an actual question, you would have gotten -20 in this particular question. So if you see, Roma ma'am has now typed XXX in the chat box. After this only you are supposed to answer. So the second hint is he has 3 sisters and one of them is a Bollywood actor. So
Team 1.
Arjun Kapoor.
yeah, so I think that is the correct answer. So for this, team 1 will get +15. Okay.
Sir, I just wanted to clarify that are we supposed to hit the button after you complete your question or after it appears on the screen?
So after I read out the question, you answer then only.
Because if you answer it wrong, then you will get negative marking. So don't be in a hurry. Yeah.
So the negative marking is very heavy. So remember that. Okay.
Thank you, sir.
Yeah.
So since the answer has already been given, so we are not going to the other 2 hints. Yeah. Okay. So
all teams be ready. So we'll go with the first condition.
Let me put XXS in the group. Yeah. Okay. Shall I start, Dr. Samir?
Yes. So this is a systemic condition with ocular involvement with no hereditary pattern and has angiomas of pial layer of meninges. So if no team answers within 20 seconds, we'll move on with the next hint.
They're scared about the negative marking.
Dr. Roma, let us know. Huh? Okay, team 1 has
Team one.
Team 1.
Is it
Team 1?
Sturge-Weber syndrome, ma'am?
Yeah, it's correct. So plus 20 for team 1. Great.
Great.
I'll type X66, ma'am.
Yeah, but already it's been answered, so I think.
Yeah. For the want of time, we'll just proceed further.
Okay, so correctly answered, team 1. So now there's an audience question.
Yeah. So we can move for the audience question. So which procedure is the best treatment option for the repair of a large upper lid defect? A. Cutler beard, B. Hughes, C. Bick, D. Fasanella serval. So Sampurna Raj has answered first. So you can unmute yourself and answer.
The answer is A. Cutler beard.
Yeah, that's the correct answer. Cutler beard is the correct answer. So we'll just congratulations, Dr. Sampurna Raj. So we'll move on to the next question. So second conditions, all teams be ready. This is a panuveitic condition which recurs as episodes of anterior uveitis. So just to clarify, the recurrence presents as anterior uveitis, like more commonly manifests as anterior uveitis.
Okay, team 5 has written. Team 5.
Yeah.
VKH?
Yeah, that is the correct answer. So plus 20 for team 5. So just to clarify, when VKH manifests, it's more of a panuveitis involving the posterior segment as well. But when it recurs, it more commonly presents as anterior uveitis. It involves the anterior segment more commonly.
Well
So
done.
we'll move. So next audience question. So audience, be prepared. The most common fundus finding in a patient with acute traumatic optic neuropathy is A. Disc edema, B. Disc pallor, C. Choroidal rupture, D. Unremarkable fundus.
Again, Sampurna Raj.
The answer is D. Unremarkable fundus.
Yeah. So that is the correct answer. Usually, acute traumatic optic neuropathy can manifest in many forms. It can also occur as disc avulsion, but usually it is an unremarkable fundus pallor setting in after almost 20 to 30 days when optic atrophy ensues. So we'll move on to the next question. The third condition, teams be prepared. So this is a rare cicatrizing conjunctivitis, can progress to end-stage corneal blindness without treatment.
Team 5.
Team 5.
Sir, is it ocular cicatricial pemphigoid?
Yeah, that's the correct answer. So team 5 again gets plus 20. So we'll move on to the next audience question. So all of the following are necessary for the generation of MRI images except A. Atomic nuclei with electrical dipoles, B. High power magnetic field, C. Radio frequency energy pulses, D. Water and calcium. Yes, Dr. Sampurna Raj.
Is it C. Radio frequency energy pulses?
No, that is not the correct answer. So the correct answer is water and calcium. So actually you require water and hydrogen for the generation of MRI images. So we'll go on to the last condition of this particular round. So teams, be prepared. Okay, I'm yet to see any negative marking, so I hope someone gets negative just to make it interesting. So identify the strabismic syndrome. So the images are shown, the 9 gazes are shown. So you have to identify the particular strabismic condition. If you're not sure, if no team answers, then we can move on to the next hint.
Team 2. Team 2 want to answer this question. You can unmute and answer.
Brown syndrome, sir.
Yeah, so that is the correct answer. So team 2 gets plus 20. Great. So we are done with the third round, and we'll move on to next round. Before we move on to the next round, Dr. Roma, would you like to summarize the points or the marks that each team got in this particular round 3, just to avoid any confusion?
Okay. Team 1 has got 20 points, team 5 has got 40, and team 2 has got 20 points.
Okay. Okay, fine. So we'll move on to the next round, which is the Wordsmith War grid find. So each team, so this is team wise, okay? Each team will be allocated 1 minute. So each team will be projected with a grid of words on the slide. One player from each team will answer, identify 6 ophthalmology related words in the grid, and there will be +1 for each correct answer. So there is no negative marking. You can answer whatever you want, but there is a time limit. You'll have 1 minute to do that. There are 6 words. Okay, and only one person should answer. Okay, make sure that only one person answers, so we can probably move ahead. So trial round. So it's basically a mixture of fruits. So probably we can just show them the answers. Yeah. So if you see, you have to identify, there will be 6 words in the particular grid, and you just have to make out those 6 words. Although here we have fruits, in your particular grids we'll have stuff related to ophthalmology. So let's begin with the first team, which is team Optic Oracles. So your time starts now. Team 1. Team 1, are you there?
Yes, sir. I'm just going through it.
Okay,
Okay.
fine. Examer.
Yeah, correct.
Okay.
1.
Yes, sir. It's wavefront, femtosecond, cryoprobe, lensometer, prism, and
Yeah,
examer.
correct. Yeah, correct. All 6.
Thank you, sir.
Great. So let's move on to team B. Team 2, be prepared. Okay, we'll start the time as soon as the grid is projected. Okay.
Yes, sir.
Yeah.
Ready?
Yes, ma'am. Cortex, brittle, phaco-dynamic, sling, IOL master, smile.
Yeah, correct. Great, excellent. You got all 6 correct. So +6 for team 2 as well. So next, let's move on to team 3.
Team 3, are you
Analysts are
ready?
when?
Yes.
Yeah. So time will be started as soon as the grid is projected.
Trochlea, syringing, glaucoma.
Only one person should answer.
Glaucoma, periosteum, choroid, viscoelastic, trochlea, syringing, glaucoma, periosteum, choroid, viscoelastic.
So one word is still incomplete. Like you have answered a part of it.
Choroiditis.
So I only one person should answer. I told that before also.
Choroiditis.
Okay. Okay, +6 for team annulus of win. We'll move on to the next team. Synergistic squad, be ready. Okay, time will start as soon as the grid is projected.
Probing, peribulbar,
Okay.
vectis,
Okay. 3 more to go.
slide, nucleus,
Okay. 2 more. I think the time is up. Dr. Roma?
Dr. Roma, are you there?
Yeah. Yes, yes, yes. They have answered 4 correctly.
Okay. So the words that you missed out were cyst and light. Okay, so +4 for team 4 synergistic squad. So let's move on to the next team. Team 5 sight seekers. So be ready. The time will start as soon as the grid is projected.
Retrobulbar, retinopathy, vitreous, photopsia, vision, and macula.
Okay, so +6 for team 5 sight seekers. Great, excellent. So with this, we end the round 5 and all the round 4, and all the 4 rounds have been conducted, and you are awesome. So with this, I would like to invite Dr. Mosami for the presentation of the certificates to the participants.
Yeah, thank you, Dr. Samir. So congratulations, everyone. You guys have done a wonderful job. The round 3 and 4 were new to you guys, but you guys just aced it. So we'll just present you the certificate of appreciation. Dr. Vinita, Dr. Neha, Dr. Shovna, Dr. Anvi, Dr. Anji, Dr. Ritik Jain, Dr. Rakshita, Dr. Amisha Mathur, Dr. Gagandeep Kaur, Dr. Shriti Soni Thampi, Dr. Priyanka K, Dr. Arvind Krishna, Dr. Hiba Abdul Rauf, Dr. Shruti, and Dr. Haifa. So, thank you, everyone. Okay. So, the results will be declared by the evening. And yeah, we are looking forward to see you guys in YOSICon 2025. And all the best to all the finalists, and whoever doesn't make it, even then, you should congratulate yourself for doing such a wonderful job. So, do we
Thank
need
you.
to? Yeah. Anything else? Any of the teams wants to say anything?
Mr. Sai, we can go offline.
Good evening to Team YOSI. Thank you for such a wonderful opportunity and such a nice platform for us to explore different fields of ophthalm and to have an interaction with all the top personnel of the ophthalmology in India. Thank you for giving us this platform for the same.
Thank you, Dr. Smithy and Team Macula Goals. I think all of you, all the teams have done a great job. Coming like you have come a long way, being second, third year residents, and like presenting on presenting such beautifully on topics and answering the questions from judges. And obviously the reels, making such creative reels and all. So great job. All of you are winners. Okay, so it doesn't matter who comes first or second, and keep it up. You guys are doing a great job.
Thank you so much, sir. Thank you, ma'am. Thank you for giving us such a huge platform, and also for always keeping that reels round, because that helps us bring out our creativity as well and to do something different and out of the box. And thank you to all the judges and our mentors. Thank you so much.
Thank you. Dr. Roma, would you like to say anything?
No, thank you so much. It was a wonderful presentation. Everyone has done really well, and thank you. That's all.
Okay, I think then we can call it off. So we'll be announcing the results by evening. So all the best to each and every team. We'll just compile the marks and share. Thank you. Thank you everyone for joining us. Thank you. Mr. Sai? Mr. Sai, are you there?